myelopathy is the case of spinal cord compressed that everyone know. But in the past, we used the endoscopic for the foraminotomy in the cervical, right? But right now, many surgeons try to do with the endoscope in the CSM case. This is the classic paper of the randomized control trial. Right now, we have to file and with him. Improve about the pain, functional outcome, and imaging result significant. Yeah. For the indication for posterior approach cervical endoscopic, we can use in the CNR, CSM, OPLL, but you got to choose in the case of the K-line positive or neutral. And you have to make sure for the instability of the cervical. Yes, you have to know about the V points for docking and start the procedure of the decompression. For the position, the same posterior approach in the conventional approach, but for me, I use the only staple, like Professor Monoportal says. We don't need the skull traction because we're concerned about the neuropathy of the brachial plexus. And you have to upraise the head around 15 to 20 degrees for decrease the intracranial pressure for the patient. The inter-op level you have to learn for the coronal view. It is the best of the view if you need to count the level. You have to try to find AP view for find the lead one and you count up to your pathology. This is my case. She 45 Thai male. He had a spastic cord, so and for long time around 6 months. And this is some of my sorry, not work. Okay. He has a hand grip release test is positive, so this case is fulfilled. Sorry. And diagnosis the CSM. Maybe my video is not work. Okay. And this is his imaging. This is MRI. You can see the myelopathy is occur where this rupture. Maybe for this case he is lucky because the rupture this is lateral more central, not more lateral, not more medial. My diagnosis is CSM and I plan to do with my procedure. Okay, I'm lucky the video is shown. The first step you identify the V points first and you start deal the upper lamina, the lateral two facets and try to preserve the facets. So for me, for my experience, I only trim the facets around 4 millimeters. Okay. After trim the facets, to go down to the lower lamina, and it's better if you use all burr like Dr. Monoportal says. But sometimes you can try a little bit with the thin curison to nap some piece of the ferrum ligament. Sorry. Maybe not work. Okay. After that, after I decompress both sides, I mean contralateral too. So I try to discectomy. For this case this was calcified. That is a problem. You have to break calcify and try to remove the disc. I recommend you don't distract the medial of the cord because maybe an injury, and we have to use the neuromonitoring to monitor all the time all your field. You can see this is the lateral more central. If central disc maybe cannot remove. Okay, and finish. My video not work. Okay, this is a 12-hour post-operative patient can walk and come back home in the same day. It's a wound. So I use the stenosis endoscopic. So my wound is bigger, 10 centimeter. Okay. Another case, the 72-year male. So he has a status post-diagnosed poliomyelitis around 40 years, and he came with a weakness, sudden weakness, only 7 days. So before weakness, he can walk like a polio walk, right? You know. This is the imaging. I have only MRI for this case. You can see the MRI show the facet cyst like a tumor, but this is a facet cyst. Maybe have a lot of case report in the paper. This is my video view surgery. I start like a first case, decompress first for bilateral decompression. After that, try to identify the border of the cyst. After that, try to remove gently. This is my quick video around 2x. Maybe too quick. And see. After that, try to stop breathing. I recommend you use the pressure for the cervical 30 to 40, not more than 40. Okay. When you work the bone work, you use the 40. After finish bone work, you decrease to the 30 to 35. It's a better. Can prevent the increased intracranial pressure. Okay. It is post-operative patient still from grade 2 up to grade 4. Video not work. This is 1 month post-operative patient came to walk the same before the surgery. Okay. Another case is the last case for me. 74-year male. He came to me with the adjacent syndrome disease on the cervical and have a myelopathy. And I diagnosed CSM, but from the adjacent syndrome. The patient was surgery about non-decompression around 10 years ago. You can see you have to check the stability first for this, because this case is not first case. Okay? It's MRI. You can see the spinal cord was compressed at the cervico-thoracic junction. I plan to do decompression with the endoscope. It is my video view. in the revision case, you have to use the bone landmark with the foot, and you try to find the bone landmark first. After that, you identify if the patient have some of the virgin area. You try to start with the virgin area. Okay, so you have to decompression first, like two cases before. This is the upper lamina and trim to the medial facet. Lower lamina. For this case, I do over the top technique from the another side. It is another side of the contralateral side. You can use all burr for your field, all burr like Dr. Monoportal. After that, you try to dissect with the dissector, and please keep the content or the fibrous ligament. Try to move with the arm walk or the half of the arm walk. Okay. The benefit is it can prevent the pressure from the water. For the thoracic, we concern about the pressure of the water and the cervical time. For this case, most of my case in the cervical per level, I use around 30 to 45 minutes. So most of my case, I do multi-level decompression by only one surgical, only one approach. Okay, but in the case of this, maybe we cannot do only one wound. We have to separate and you apply the rivet in, and it's complete. Sorry. The motor of the patient from gate 2 up to gate 4. Okay. In 12 hours. It is a benefit of the early surgical. Okay. I have just a little bit in my experience for the CNM case. So most of my case, the result is good to excellent for 1 year follow-up. And we know already the endoscopic is better and benefits, but you have to concern about the complication like duratec. But the serious is the vertebral artery injury that form the tip of your RF. And I have to say thank you, my mentor, Dr. Pornpavit Sipirom, and thank you for Indian country and welcome me to presentation this year. Thank you.